think we'll make a start. I'm conscious of people's time. We've got quite a lot to get through this session. So welcome everybody to this bi-monthly Recondition the Nation Ambassadors meeting. It seems to be growing nicely. Again, quite a lot of people requesting to join, so that's nice. We have it's around over 500 people on the list now connecting to this group, and I think this is the year that I think we'll probably have a discussion at the next meeting about what is the focus for this year. But I think it's about how we can bring a lot of the activity around the country that's happening in this space in general, and bring it all together under the same umbrella if possible. You know, it's all about, we're all trying to do the same thing, and I think it's about how we connect with each other in many different ways. And there isn't one way of doing this kind of work. There's many different flavors around the country, and it's all, you know, hoping to do the same thing. It's how we kind of connect that together, which is my aim and hopes for this year, and grow the network as big as possible. So today, this is a chance to sort of hear a lot from last month. Well, the last session was really a more of a sort of discussion session. This is another chance to hear from lots of different people doing some great work around the country. We've got a few people on from Bristol and Weston, which would be great to hear about their work, the active hospitals work. See, Becky's here from UH&M, University Hospital North Midlands. We're going to, I did see Kate pop up a minute ago. Kate Tantam's around as well. So from Plymouth. And then I think Joe's going to join us. Joe McCauley's going to give a bit of a shout out to a request for anybody who wants to join some of her work she's involved with. So she'll probably join us at some point if she's not already on the call. So but first and foremost, I'm going to hand over to the illustrious Dr. Amit Arora, who's going to give us a bit of an update. One of the things I think for this meeting is about how we can connect to a lot of other work that's happening. Amit is really well connected around the country to, as Vice President for the BGS and some of the national conversations. Amit can bring a bit of an update in terms of what's happening outside our world as well, and see if we can connect that up. So I'll just give Amit sort of 10 minutes, if possible, just to give us a bit of an update in terms of what's happening around the country. So Amit, anything from your world?
Yes, thank you and good afternoon. And on behalf of everybody here, I welcome you to the first meeting of our Recondition the Nation ambassadors for the 2024 season. So let me get back to the last year. I think it was sometime around March when we launched the Recondition the Nation work, following the brilliant work done by Debbie and Geraldine from East of England in the work on the East of England deconditioning games, which was absolutely stunning work. So thank you to Debbie and Geraldine and the teams that were part of that. I think the purpose of the Recondition the Nation was twofold. One was to improve patient outcomes by reducing deconditioning, and the second one was to improve staff morale and bring joy to their work in the day-to-day job. Last year, when we said what we will do in the inaugural speech, we said we will establish a network of reconditioning ambassadors across the country. And we are all here, and there are many more who are not here today at the moment. So that mission to establish that network is complete, but it's not complete because it's always ongoing mission. So please do encourage your friends and family and patients and relatives and hospital staff and care home people and council colleagues to join in this network. So last year we saw the involvement, the active engagement from over 1,500 teams across 34 ICSs, and plenty of medals, certificates, and badges were given out. And thank you, Nick, for doing all that work behind the scenes. It's just, I mean, I can't even start to imagine how much effort it takes. And Nick is the one-man army behind all that amazing work that he does so successfully. In particular, I think we also saw a lot of platinum awards, which were given to individuals and organizations for their sterling work in this field in terms of prevention of deconditioning, in terms of creating new roles, in terms of giving colleagues an easier passage to do whatever they wanted to do, because that's not easy, because a lot of organizations will put up a lot of stumbling blocks for things that you may want to do for patient benefit, and it's not always easy. So to recognize that, we also gave some organizations those platinum medals for the fantastic work that they enabled their teams and gave them easier passage to do that. What we also saw was that we also saw a lot of new, innovative, effective methods that you developed on your own, based on what your needs are, what your patients need, what facilities might be available, sometimes at no cost, sometimes at very low cost, and sometimes at maybe higher cost. And for those who've done it at a higher cost, also need to be really congratulated, because in the NHS, it's not straightforward to get any money. Even for £5, you have to go through about 25 emails. So if you've achieved £1,000 from somewhere, that's absolutely sterling job, because it's not easy, as we all know. I think apart from what you did yourself, I think the most important thing that we did was that you enabled, you encouraged, and you enthused others to get involved. You included your friends, family, executives, dinner ladies, porters, colleagues, other staff, care homes, but you also produced what is now a social movement. What is amazing is the public understanding of what deconditioning is, what the harms are, and how often do I now see patients and families and doctors and nurses saying the word deconditioning? If I go back to 7 years, about 2015, when we first started this, and if I've asked somebody, well, this person has got deconditioning syndrome. What? What is that? Say that again. That was the attitude that I used to get. And that has changed. I even saw in the diagnosis, in discharge letters, in the admission clerking, deconditioning. I've even been asked by colleagues, should I put deconditioning in the death certificate? So it's that level of understanding amongst the execs, that level of understanding in NHS England or Department of Health. That is amazing. In the scientific community, NIHR. So I think that awareness that you've generated is absolutely amazing. What else have the teams done? I think teams have developed new roles. So the organization where I work, and
Can't get the sound to work. There's always a problem.
you'll hear from Becky a bit later, and Leanne about the new roles that they've established, the diversional therapy roles. And I know from other organizations that others have done very similar newer roles. And I'll let Becky talk about it. But also a lot of colleagues and teams who have taken part in various awards for HSJ, for nursing times, and so on. They have kind of been there, been a finalist, some have won the awards, and so on. A lot of people have raised their own profile and the profile of deconditioning and rehabilitation in their own workspaces, etc. And the world of Twitter, X, is full of examples which you could easily replicate, and you could post what you're doing there, and what amazing work that you do in your own patches. I think nationally, as I said, the program to recondition the nation has been appreciated at higher levels of NHS and Department of Health. We've also recently started to collaborate with Sir Muir Gray, who most of you will know is a living legend in this field of medicine, a truly inspirational figure in public health and active aging, and his amazing network of active partnerships. So his active partnerships are an amazing model, which basically locality-based active partnerships. And I went to one of those recently, having been there before, and we have asked them to come and speak with us and guide us in our March meeting. So hopefully we'll hear from them. And of course, we also have our own, the great Brian Dolan, who constantly supports us. The BGS, the British Geriatric Society, is a strong supporter of this work, and so are the higher decision makers. For example, Jenny Keane, the National Director of Rehabilitation, is very keen, and she's been to one of our network meetings to talk to support the campaign around reconditioning. So she is quite keen. I think we are currently also working on seeing how we can improve the community hospital productivity improvement, for example, but that is not limited to community hospital. It might be it will likely include care homes and so on. So that will also support the reconditioning work that you are all involved in. So we have lots of people working in this field, and more want to join in. And because this is the right thing to do, I think the challenge remains that how do we connect these various pieces of work happening in this field, and how do we continue to try and build those networks to enable everyone doing what you do, which is undoubtedly a brilliant job. So colleagues, you are changing cultures here, and you started a real social movement. It's not an easy task, and you probably are doing it above and beyond what you are normally meant to do, and you should all be so proud of yourself. The benefits of this work are economic too, because there is lesser health care usage, lesser social care usage, lesser hospitalization, less amount of sick days, more productivity. But more importantly, I think what it also does is it actually generates the confidence in the family members and patients and so on, and we are restoring the trust in the NHS. I mean, it feels really awful, and I really feel hurt in saying that. But more lately, we've seen evidence that the trust in the NHS, in the public domain, as well as in the staff domain, is kind of getting a bit low. But we are what we are trying to do is we are also increasing that level of trust that somebody there is actually doing something genuine about this. The other bit I wanted to say to you was that although the majority of the teams in the Recondition the Nation work was from hospitals, but please do include care homes, councils, communities, voluntary sector, other organizations, village halls, and so on, to help us, to support us, to guide us, to join this movement, to spread the word, and that will basically contribute in a small way in improving the health of the nation. So I give you my pledge again, and the pledge from me is that I'll continue to support and help people in making this possible, and I'll provide you what I can do, which is a really precious thing, which is the time. And the time really is precious, and I'll promise you all my time in developing that. And if there are any queries, etc., please do email me directly. I will always respond. But for the purpose of now, we have got the amazing team from Bristol and Weston, then we have the team from University Hospital of North Midlands, and then we have the amazing Kate Tantam. So I will leave it here for now, but I thank you all for your fantastic leadership in making this mission to recondition the nation possible. And I will see you. I'll be here for the meeting, but I'll see you in March and by email in between, whoever wants to contact. Thank
Brilliant.
you.
Thank you, Amit. Just before we hand over to Scott and the team, just to reinforce that about what I'm starting to see now is those non-acute participants now, people joining this group. Is really great to see that there was somebody signed up from public health background. So I want to sort of learn a bit more about what's happening in the public health space around deconditioning. But that's a really important element. A shout out to, I can see they're on the call, to Debbie Edgell and Josh Paul. If anybody caught the ward-led enablement session we put on recently, the lunchtime learning event, I'll put the link in the chat in a moment. Others are doing something similar, but I think it's a different way of looking at things about how we bring that enablement service upstream a little bit more in terms of that, not waiting until the patient has left the acute to start that enablement work. It's a really great example, and I think some real demonstrable evidence around how that is having an impact on length of stay and patient outcomes. So I'll put that in the link in the chat as well. So got lots to get through. So Scott, team from Bristol, great. Bristol and Weston, great to see you. And I see my old friend Deirdre Fowler's here as well, so great to see you as well. But I'm going to hand over to you. The floor is yours for the next 20 minutes ish.
Great, thanks, Nick. Hi, good afternoon, everyone. My name's Scott Allen. I'm Head of Adult Therapy Services here at UHBW. Also on the call from Bristol is Juliet, Kirsty and Beth. And as Nick just said, Deirdre's also on the call as well, who's our chief nurse. The way we're going to do this is I'm going to give a quick summary of what we did around active hospitals. Kirsty is then going to present a presentation that the three of us have pulled together. And then Beth is going to do a quick summary at the end around some of the work that we've done with dementia, delirium and falls projects here at UHBW as well. So hopefully it will give you a summary of what we're doing, where we are and where we're planning to go next. So just around active hospitals, myself and my counterpart at MBT applied for some joint funding for active hospitals coordinator role through Age UK Bristol, and we were successful in getting that bid supported through our chief nurse here, Deirdre, but also through Age UK Bristol. And obviously that role was to try and support and help our patients here at UHBW across both sites from deconditioning whilst they were here with us. Myself and my counterpart decided that we wanted to go for a full-time post with MBT, and actually the post works that it's a part-time post across both sites, and we went for that model because we wanted to have one person working across both sites being able to help share that learning across both sites. It made it a joint working project, but also we were able to share all of that learning across both sites both ways. Kirsty, who's with us now, is our active coordinator, active hospitals coordinator, and Kirsty, myself and Juliet have pulled together the following presentation that Kirsty's going to talk through, and there will be some questions at the end, there'll be some time at the end for anyone to ask any questions from the three of us if they'd like to. So Kirsty, I'm going to hand over to you just to go through the presentation. I'll drive it from this end, but if you want to tell me when you want me to move forward, I'll do that.
Thank you, Scott. Thanks ever so much. Hi, everybody. I've been a participant in these meetings, but to be on this side, it's always a bit awkward, isn't it? So, but pleased to be here. So looking at this first slide here, that is actually some of the patients at BRI on one of the trauma and orthopaedic wards. Once we found them a table, they couldn't wait to get dressed, get up and get into the middle of the room. So that sums it up. So one of our pilot wards, that's actually a group of the patients, and they thoroughly enjoyed their social lunch in the middle of one of the bays. If you can move on, Scott. So this is why we're all here. The date circled in the red, 1947, and the note here, if you can see part of this extract, it says doctors are assessed by their bedside manner. Bed is not ordered like a pill or a purge, but assumed as a basis of treatment. If you read the rest of that while I talk, and it's quite sad really that in 2024, we're still having those same conversations. Teach me to live. I may dread the grave as little as my bed. We have bed numbers, we say bed areas, we put patients into bed as soon as they come into the hospital, even if they don't need to, etc. So this is why we're all here, isn't it? So it just reflects back. Thanks, Scott. So in case some of you weren't familiar, we thought we'd sort of take this step back to active hospitals and the aims. So it really is trying to change a culture. As Amit said earlier, we're all here to try and change this culture. It's not going to happen overnight. It is going to be a long process, but every little we can do tries to increase that profile of being physically active and moving more. We generally use the words moving more, and promote mobility as much as we can. We need to educate not only staff, but obviously patients, but also their families, because often the family are happy for them to be in hospital, and don't realise that actually they don't need to stay in their bed gowns and in their bed. So we need to work with patients and the families too. Obviously, we want them to be independent as soon as possible, work towards going home. We need to increase that flow through the hospital. So those are all aims of active hospitals. And for the patient really to take some responsibility for their own recovery is key. So we need to educate them. They need to take part, not just have care done to them. Thanks, Scott. So way back, we set up a steering group, and then eventually we got to some subgroups looking at a little bit more on the delivery and what were we going to do. And this is just an overview of what everybody felt active hospitals meant and what our sort of pledge to this was, and then some more detail, but basically getting the patient back into a normal routine to be able to get them to go home successfully. So the first thing we did, if you move on, Scott, we started some audits. We decided that we would like to look a little bit closer at what we could deliver, what we could action, what we could record, and what we could learn. So we did the out of bed for meal times was one of the fundamentals. So clearly an opportunity to move a patient. Obviously, it is better for everybody to sit up, and we know the reasons why to eat out of bed, but it was an opportunity for movement. So we looked at whether it was being done, what the base rate was, how many patients were out of bed. We wanted to know from our first audit, just a number, how many out of 25 beds were sat out of bed for each meal time, breakfast, dinner and tea. So we did an audit for that. Then we wanted to look at promoting mobility. And I started off my work with MBT, so North Bristol Trust, the other acute trust I'm working with, and we had some surveys of the patients in February, and then did it again in July, and it came up with one of the things that the staff felt was the multidisciplinary team working together and communicating was a little of an issue. Falls prevention, worries about falls was another element, and but obviously pressures on staffing and staffing numbers. So this promoting mobility and getting the multidisciplinary team came from that. And UHBW are definitely striving to look at the ways that the whole team on a ward can work together to make sure that the patient progresses, but progresses steadily, moving through and moving more. So use of whiteboards behind the patient, ICANN charts. We're just designing some different ICANN charts, making it specific to the patient's needs, and then also looking at goal setting. So if a patient wants to get home with a walker or maybe a stick instead of a walker, then we know that that's the goal. They've got a dog to walk, that's their aim. Then we talk about them. How can we get you back to that sort of process? Personal care is another opportunity. This is going to be our next phase of looking at getting patients to go to the toilet, walk to the toilet, and help them with that process, getting dressed, getting washed, that sort of personal care. But we're concentrating mainly at the moment with that out of bed for meal times initially. Age UK Bristol have been able to find a small bit of funding for some activities and equipment. So I've distributed that amongst the pilot wards on both trusts, which could be from Connect 4 games to balloons, balls, woggles, all the fun things that we've seen and we've shared on YouTube, as you say, with the reconditioning games. Thanks, Scott. So our first research, as I was explaining, is into the patients out of bed for meal times, and this is just a snippet of a report that we did. So the wards were asked over a 2-week period, could they do 6 days, and it was breakfast, dinner and tea. That's what we required over that period of time as a snippet of how they were doing. And obviously you could see The second ward, for example, they went away, tail between their legs. Right, we need to get our act together. We need to do something. Why are we not performing as well as others? You can see that breakfasts, there was a general theme that breakfasts and even dinner were not as good as lunchtime. So we considered the elements of why, but it was a really good insight initially with that first audit. Then we felt from that we needed to look at a second audit that said, why are they not out of bed? Not just yes, no, but why? We needed the people doing the audits, which was mainly staff and ward managers, to ask the patient why, find out why they weren't out of bed. And that's been really good insight. We're literally in the middle of that at the moment. We're just getting the data back from all the wards, but we've had lots of comments, some fearful of falling, fearful of sliding off the chair. Some patients just saying, I'm lazy and I just don't want to. So it's highlighted that we need to have more of a motivational conversation with some people, but we also need to support other patients that might be worried and fearful of sitting out in a chair. So we're working on phase 3. We hope to put in some interventions, which will be things like matrons doing peer training, going onto the wards, supporting ward managers, mentoring, information sheets for staff, patients and their families, so we get the patients involved to understand why are we asking you to get out of bed and sit in a chair. When you're sat on a bed and you look at the chair next to you, it's like, well, why do I need to sit in the chair? So we're coming up with some sort of make every contact count sort of conversations that staff can have. We've got notice boards going up soon with active hospital promotion. So again, visitors onto the ward and patients get a feel for it. We've got some of our practice education facilitators going on to do T-trolley, sort of micro training for staff, confidence building. We've also got an e-learning that was set up at MBT and we've transferred it over and rebranded it to be UHBW use as well, which is really good sharing of resources. So that's rolling out, and each week we're just making sure that we're getting more and more staff trained for this, enabling skills for clinical staff training. It takes about 10-15 minutes, so we're hoping to just get as many staff through that as possible. Manual handling and health and safety are very much involved, increasing that mobility element of their manual handling. And we're hoping that the comms have just started to put articles, the ladies at the beginning on the front slide, they're going into the news beat so that staff are aware of some of the success stories. Thanks, Scott. This is the sort of moving on to the, it's going alongside really that, getting people out of bed for meal times. But this is where we're looking at these whiteboards behind the patient's beds. So this is the layout. It will have the active hospitals logo. One ward has already got these up. They've just had the ward painted and they've just got these boards up. So we're going to monitor and see how they work. And to the right, using the moving medicines ICAN, we're just looking at tweaking that to how UHBW would like to use that across. And as part of that, we're also going to have, we have My Journey volunteers. So they go onto the wards and they interview patients about various things. And the My Journey volunteers are going to take the new design ICAN when it comes through to the patients and say, what do you think of this? What do you think of the content? What do you think of the use? This is what we want to use to set your goals, record your mobility. Are they happy with maybe their continence? If they have continence issues, do they want that on there or not? So we're going to ask them. So we're going to go through a consultant process with our patients through our My Journey volunteers. So we hope to launch those in the next couple of months once we've consulted with the patients, and then we can roll those out again with the training that we're putting in place. Thanks, Scott. Yeah, so this was, we've been asked at the moment, because it's coming to the end of my time with UHBW and MBT in my role, end of March. The Active Hospitals programme has no more funding to continue. So we're being asked to sort of report back on our metrics of data of, you know, how are we improving flow? Are we reducing discharge, pathways, etc.? It's very early to be able to give much response, but this was a great, we are contributing to this decrease the increase of flow. There is literally a downward slope, as you can see, which is great, and active hospitals is clearly part of that, but very difficult to say whether pressure injuries, falls, etc. in the time that we've been doing it since September. Where it got embedded into the 6 pilot wards, it's been really hard to prove at the moment because we're still working on the interventions, really. So if anybody's got any sort of knowledge or feedback or any ways we can, can help us with that, that would be brilliant. But the general flow is going down, so that's great.
Kirsty, can I just add in there? I think most people will know on the call to try and unpick flow and discharge specifically to your project is really hard, and that's hence why on this slide we've said contributing, because we can't unpick that specifically to say it's therapies, to say it's this, to say it's that. So that's why we put on this slide it's contributing. It's supporting that process across the trust. Sorry,
Yeah,
Kirsty.
Thanks. No, totally, absolutely fine, Scott. So, yeah, I think that's been one of our hardest, but we're now looking to UHBW to look to roll out the programme wider. So we're just making sure it gets embedded into our training, where we do healthcare support worker training for new inductees, so that as soon as they arrive to the hospital, that they're now starting to feel they are part of an active hospital. And it would lovely, the idea is UHBW really to become an active hospital across, rather than just the 6 pilot wards. So yeah, thank you. Thanks for listening.
Great, thanks, Kirsty. Nick, what I'm going to do is ask Bethan just to do her 4 slides, and then as a panel or a group, we'll take any questions if there are any. Is that all right?
Yeah, no problem.
Bethan, are you happy to go through your couple of slides?
Yes, thank you for inviting me. So I'm a dementia, delirium and falls nurse, and we've been running sort of 2 projects. One was a project pre-COVID, which was the dementia stroke memory cafe that we used to run. Obviously, that's been suspended sort of during COVID, and we've just started reintroducing it across the hospital. The other one is we've been doing the Dementia Garden project. So what happened is our support worker in the team applied for a grant to our local charity here in the hospital. We were successful in that, and then what it's allowed us to do is to work with the Alive charity, who do a lot of work in the community. This is their first time coming into the hospital environment. They do a lot of work with dementia patients in the community, in residential homes and nursing homes. And then what we've managed to sort of start is a weekly garden project. So we are an inner city hospital. This is absolutely desperate for green space, but we have got a little courtyard garden, and what we try to do is utilise that area and use it with the patients. So every Wednesday afternoon we hold a gardening club for about an hour and a half in the afternoon. We've been very lucky to get some funding for a healthcare support worker who goes out early in the morning. She identifies patients. We also work it with hospital wards. We link in with the enhanced care observation team to see if there's anybody that can identify that would benefit from the gardening club. We're really looking for patients who've got a dementia, who've got a cognitive impairment, or maybe who've been in hospital for a long time. And the healthcare support worker will go out in the morning. She will identify those patients. She will encourage staff to make sure that they have got dressed, that they are ready for the gardening club, because the criteria is that they come sort of like dressed in their own clothes, because it is part about engaging in activity. We're also in a public area, so I think it's really important for patients to be in their own clothes to undertake the project. And we've actually managed to get, we've asked for donations of clothes, so if patients haven't got their own clothes, we can support them to get dressed. Encourage them to come after lunch, so to see it as part of an activity. We've started in September, so I think some of the challenges have been around weather, because it is outdoors. So at the beginning it was quite easy because the weather's nice. as obviously we've gone into winter, we've had storms, we've had sort of very cold weather. We've just adapted what we've done. We've linked in with the activities coordinator, which is a role that's been trialled here, and used their day room. And we've also used, there's a cafe atrium. It's quite a nice wide open space, but it's indoors. So we've been able to hold it and adapt it. And actually the key elements are about activity for the patients, getting them off the ward, communicating, talking to different people, and then also undertaking a project. And actually they don't really see it as sort of like physiotherapy, but actually they are you know, picking up equipment, they are planting. So even if somebody isn't particularly very mobile, we're able to do activities at a table. You don't have to be Gardener of the Year to come along. So a lot of our patients feel that they need to be a gardener, and we say not at all. If they don't really want to do an actual planting, potting, gardening activity, we've got craft activities. So whether that's making bookmarks, whether that's looking at magazines, it's really about engaging in conversation. Really encourage relatives to come. So we've had relatives come along and really enjoyed doing an activity with their loved one. So at Christmas we did a Christmas wreath, and a husband of one of the patients' comment was, this is the best thing I've done with my wife in many years, and asked if he could take the wreath home and hang it on his front door. So it's really about pulling in sort of like relatives, carers, other staff. So we've worked very closely with therapies, and they come along. So yeah, it's really been very positive. I think it's nice for other relatives who see the activities undertaken. So we've had really positive feedback. And then the other one is the Memory Cafe, which again, we've linked in with the activities coordinator, and that's really about, again, taking patients somewhere different. We've held it in different wards, so in their day rooms, and again, encourage relatives, encourage sort of staff to come along, student nurses, and it's really about just having a cup of tea, talking. We've got lots of different activities, whether that's jigsaw puzzles, memory sort of like cards, speaking to other patients, and that again is held monthly at the moment. Hopefully going to increase that, because pre-COVID we were doing that twice a month, and again, anyone can join that. It can be, you know, anybody looking for support. We can refer on to other agencies like Carer Liaison. You know, if it's this carer strain, refer them on to other services, or you know, if they just want to come and you know, if a relative's visiting, often it's just nice for them to have a different conversation and to sit with different people. And then I just think the last slide is just some nice pictures. So that's our little courtyard garden. So we've got, as you can see, activities at the table, but also if people are very mobile, they can walk around the garden. And then we've got some activities if you know, you just want to do some craft. And that was all the lovely ladies who just sat and had a cup of tea and talked. And then there's another one of our Christmas wreath making. So it's been a lovely project to be involved in. I feel very privileged to be involved in it.
Amazing, thank you.
Hopefully, Nick, that gives you a summary of some of the work that we're doing, and that's a very light touch, but hopefully it gives that summary of the work that we're doing. Brilliant,
yeah, really great presentation. And I was going to come to Deirdre anyway, but she's beat me to it. So go on, over to you.
Yeah, hi Nick and everyone, and thanks to the team for spending some time today to come and share their progress with you. I guess what I wanted to say is just to make reference to changing the culture from the board as well, from the board perspective, to support the work that's happening. So we've worked really hard to change the attitude to the risk of falls, in terms of If you move patients, if they walk, if they are mobile, there is a small risk that they will fall. And actually changing the board's approach to the balance of risk between a fall and actually sitting in a chair and deconditioning and then leading to fall has been a bit of a journey. But I think they're there now, and I think they're used to my my little comments when they speak about volumes of fall, rather than looking at, you know, the variables and the harm from falls. So it's about really supporting the board to look at falls in relation to conditioning and deconditioning in a different way. So just wanted to give a different perspective.
That's really helpful, Deirdre, because it's really important to sort of what we see a lot is there are a lot of individuals working away at a very local level on the wards in their own areas, but it's not always connected to the executive decision making and the strategy for the organisation. And this has to be aligned. It has to be joined up. It can't just be individuals passionate about this. And I think what we're seeing here with the Active Hospitals programme across the whole trust is that there is a sense of this is how we do things around here, and trying to shift that. And I think that's the big thing that I'm hearing. So thank you to the team. Really helpful. I will share the slides. If Scott, if you can just ping them over to me, that would be great. If you're
that's
okay with that,
fine.
that's really helpful. I think you're right in terms of that, you know, causation correlation thing, but it's just about doing the right thing, you know. And if we can contribute to the overall metrics, that's brilliant. But it's about just essentially doing the right thing. Just a shout out, just in terms of what Beth was talking about there. We are thinking about how we link in some other work this year, and just to shout out that Mental Health Awareness Week in May, the theme is movement. So that links to this, you know, mental health can be across all sectors, and we know how much, particularly for our dementia patients, how much being active, being contributing to doing meaningful activities while they're with us, that greatly improves their cognitive abilities as well. So we are going to think about how we can link to the mental health week as well this year, and what we're probably going to do in the March meeting is do a little bit of a brainstorming session with you guys about how this group can link to that work as well, in terms of that wider theme for the year, just that broader movement. I think that's really a key word that sort of that strikes me from particularly the Active Hospitals programme there, is about movement. Everyone can understand movement rather than a sort of deconditioning, reconditioning. Maybe there's different connotations to that, but I think we can all get behind the idea of just movement in general is a good thing. So brilliant, thank you guys. Any questions, keep popping them in the chat if you need to. You've got the contact details of the team there as well, so if you want to reach out after this meeting, I'm sure the team would welcome that. I see Becky's
Nick,
on the
thanks
call.
for giving us
Yes,
the time to share that. That's great. Thank you.
No worries, thanks. I see Becky's all purged and ready to go. So without any further ado, we're going to hear from Becky and the work at UH&M. So over to you, Becky.
Thank you. Sorry, but not sorry. Lots of what I'm going to say is going to repeat what Scott and Kirsty have been doing, particularly my second slide, which I think will be no shock to anybody on this call, and all of the quotes and bits of literature there that show why we're doing this, where it's come from, and I note that you use my bottom left-hand little speech bubble, which is something that I refer to quite often when I'm talking about the harms of deconditioning with lots of the staff I come into contact with. What I'm here today to talk about is UH&M's journey with Johns Hopkins. I'm sure some of you will be familiar with some of the Johns Hopkins work, a US organisation that has their own activity and mobility programme. And in conjunction with our research department, UH&M have taken on the challenge of implementing this programme, and this is about our journey so far. So all of these quotes are the why. This is why we're here. No shock to any of us, but a shock to some people who aren't aware of the history and the length of time that we've talked about the impact of deconditioning. So moving on to the how. So Johns Hopkins have an 8-step framework. It's tried, it's tested all over the world. So they implement their programme by following this 8-step framework, and their implementation team have guided us through this 8-step approach to ensure that we are as successful as we can be. What Deirdre talked about that trust board, that exec level support is right there at the beginning. So organisational prioritisation is right there at the top, and that's been our aim as well right from the beginning. So making sure that everything we do aligns to strategic priorities, making sure that we've got them on board to support all the changes that we want to make. And we followed the steps of this framework as we've gone through our implementation. It hasn't been a quick journey. It started probably 12 months ago now with initial conversations about how we were going to start the project, with formal meetings starting around March time last year, and lots of those around that organisational prioritisation steps. Between April and July was a lot of planning, a huge amount of preparation, making our project team, formulating the correct staff in the room, making sure that we've got all the support that the whole project needed. Much of that support revolved around IT and planning into IT business schedules to make sure that we got the structure for the software that we were going to need to implement the programme. Across in the States, they use an electronic patient record, they use Epic, and it's built into Epic as a function, but we don't have Epic at UH&M, so we had to develop our own software. So lots of the timeline focused around that IT build. So August, September was a really busy time. They supported wholeheartedly with that build and wanted to support us with the implementation of the project. Once that build was ready, we moved on to supporting the 8 identified project wards. So we focused around older adults. So we focused on our West building, where most of our older adult wards are together. But we also reached out to our smaller hospital site across at our county site with one of our older adult wards there. And we also went out into surgery. So our fractured neck and femur ward was part of the 8 wards that we chose as our project sites. So we started off with identifying mobility advocates, so 4 members of staff from each of those project wards that we pulled together to give them extra support, extra information, extra training on safer patient handling to improve their confidence, huge support from our therapies, both physio and OT, to make sure that we got the right skills in those rooms to support the staff with that added information. What we also did, which is part of Hopkins' plan, is a barriers survey. So we sent out a survey to every single member of staff, clinical and non-clinical, and medical, nursing and therapies, to find out what the barriers to implementation may be. So that was the Hopkins survey, that is a pre-selected group of questions that staff were asked to identify around confidence, around patient movements, what resistance could be, what they would need for extra support. We took those barrier surveys and then did 3 structured focus groups with different members of the team to expand on those conversations and to support what we could put in place to mitigate those barriers as we implemented the project. We went live on the 8th of November last year, so just with Kirsty and Scott's project, it's quite new, so identifying and quantifying those improvements is a little bit difficult yet. We haven't got enough data to go on, so the 8th of November was go live. We had initially set the 1st of November back in March last year, so slipping by 7 days. We were quite proud that we'd kept on track with meeting that deadline. We've got some steps to come, so data and feedback, as you'll see in some of the slides coming forward, is one of the things still to come. So that's the when, this is the what. So this is what it looks like. So our IT team have developed a part of our electronic patient record that sits within an app of its own that staff access. And within that app, what the Hopkins programme does is ask 6 questions around activities of daily living every morning and 6 questions about patient mobility. So it looks at the patient each morning as a fresh, what can they do today? So around activities of daily living, what can they achieve today? Around mobility, what can we achieve today? And depending on the scores that are entered for those 2 sets of questions, it will generate a goal automatically and display that goal within the app. Staff then display that goal behind the patient bedside, so everyone that interacts with that patient, whether it's the patient themselves, their visitors, visitors to the ward, AHP staff that may come to that patient, nursing staff, medical colleagues, they can see what the goal is for that patient for that day. The goals vary. You can't actually achieve a 1. If you look at the scoring system, 1 is not achievable, so lying in bed isn't an option. So the lowest goal that you can get is 2, which is activities in bed or a dependent transfer. So every patient is expected to have a goal of 2 or more. And it's lovely to see the higher goals being achieved by the patients. So those patients that are working 200 feet or more, at least twice a day being recorded within the software. So as I said, we've gone out on 8 inpatient wards across both of our sites. Key to its success is making sure that staff have had the right education and support. So there is a quite hefty e-learning package that goes along with the programme that talks around deconditioning, that talks around safe patient handling, and talks about how to use the questions within the app and the app itself. So we're monitoring compliance with that e-learning package. And looking at compliance with the tools, and we can very much see that those areas that have been able to get more staff through that e-learning are becoming more compliant with the use of the tool, so it is correlating. We're keeping an eye on advocates, making sure that we're not losing advocates and making sure that that support is there for the teams, and we have got some more advocate training plans to make sure that we can keep that momentum and keep those key members of staff engaged. I talked about the barriers and what we did to look at barriers earlier. So we're continuing to work through those, making sure that we've got action plans in place to support addressing those barriers that staff identified. So we themed them into 4 different groups initially. So lots of them focused on equipment, so particularly around seating and the provision of adequate seating for patients. We tended to have not really height adjustable, high backed armed chairs that weren't appropriate for lots of our patients and was considered a major factor why some patients were not getting out of bed. So on the back of that, we've now got a specialist seating stakeholder that's happening, that's looking at a rise and recliner chair that we're going to make available for teams so that we've got appropriate seating to get as many patients as possible out of bed. But some of the comments were around commodes, the fact that they were too high, they weren't adjustable, access to turning aids, they weren't the right sort, they weren't compatible with what was used in the community, making transfer home more difficult, around therapies equipment, support that activities of daily living so that we can do practice assessments in mock kitchens and those kind of equipment issues. As well as the equipment issues around catheter strips and drains, so timely removal and whose responsibility is to say when a catheter drip or a drain can come out. Is it nurses, is it doctors? And it sparked lots of conversations around that. We talked very much around people, that perception that there's not enough people or there's not enough time, and whether that was a real thing or whether it was a perceived lack of time and people. So we talked lots around prioritisation of tasks and supporting with workforce reviews to make sure we've got the right staff and the right people and the right numbers. And we also talked about patient refusal, so included in that people section the fact that patients sometimes don't want to or are reluctant to move more in hospital and how we can support that. Which moves nicely into education and training. So looking at what education we support our patients and families with, and we've got some more work that's going to happen with that, and including the Hopkins and expectations to our families and their relatives as they come into hospital. We put the more difficult to do in the other section, so that lack of space. Space was an issue for quite a few of our wards. We lost lots of our day rooms that now house 3 bed spaces rather than being a day room, and that was something that was considered difficult for lots of our wards. So thinking about how we can use alternative spaces, looking outside, so have we got gardens that we can use and facilitate that outside space in warmer times, and looking what is there that we can use in a different way. Something else that we've been really successful with, particularly for our fractured neck and femur ward, was looking at delayed surgery and the impact that has on getting patients up and moving. So as a project that's run alongside Johns Hopkins, they've managed to secure a dedicated theatre now. So starting in November, alongside the start of this project, to looking at that dedicated theatre to support that timely surgery, which is having a huge positive impact on those patients being able to get up sooner. So what next? So we're looking at compliance. Our business intelligence team are developing some dashboards so that we can monitor compliance with the tools. So they're currently being developed, as well as looking at compliance with the tools. It's going to look at goals that are set and what patients are achieving. So we'll be able to monitor that patient movement and see how often patients are moving while they're with us in hospital. And just as Deirdre said, we're mapping that against patient harm. So we're looking at falls, we're looking at pressure ulcers, we're looking at hospital-acquired VTEs to see whether we can contribute to any perceived movements in any of those harms related to deconditioning. The next slide is just some lovely examples of Hopkins in action. So how are we getting patients out of bed? So some lovely boards that our mobility advocates have been creating to celebrate Hopkins and to spread awareness around their ward environments, and some great examples of getting patients up and moving. We love having animals into our hospital. So alpacas are a must at Christmas. They've come for the last 2 years and love coming, but we also have our regular pack dogs that come. And our mobility advocates are, quite a lot of them are our diversional therapists, and Leanne was going to join me today to talk about their role, but unfortunately the operational pressures have meant that she's not here, but she will come to a future meeting to talk about their impact. But most of my mobility advocates are a diversional therapist as well, so their impact on thinking outside the box of how to get patients engaged and how to get patients moving is great. This picture here of the craft table is a great example. This ward needed a deep clean. They needed to do it while the patients were all still on the ward. So they moved all of the patients to one end of the ward with a table. So they all got up, they all walked the length of the ward, participated in 20 minutes of craft activity while they busied up the other end of the ward, completed the deep clean, and the patients were able to go back to their bed spaces. So a great way of implementing into daily workflows the principles of Hopkins, which was fantastic. The one on the bottom right, that's me on the floor. So we played a giant game of whack-a-mole at Christmas with me in a Santa hat, and the 4 gentlemen have got some power, let me tell you, as they bopped me on the head in my Santa hat, and they had a great time. It was a great celebration at Christmas. The last slide just talks about our diversional therapy role, and I'll share the slide so you can read Leanne's description, but I won't steal her thunder. I'm sure she'll bring this to a future meeting and talk about their positive impact and the role that she's been able to create. Sorry for my tickly cough.
That's okay, Becky. That's excellent, really great, and yeah, we'll get Leanne to come and have a session on her own. But I think that's brilliant. Lots of reaction now. I think you can pick that up. Yes, you can have a good cough now and go on mute. It's well done for battling through. I think what I picked up on it, I did think for a moment you were going to talk about the deep clean and get the patients involved in the deep clean as part of the activity. I thought that's where you were going with that one, but I think it's about how we just incorporate activity to make it as normal as possible. Like we were hearing from Beth before about the gardening, or it just becomes what we do. We're not making a thing about it, where it becomes, well, why am I doing this? It becomes just normal. And I think that's what we picked up there, is this is just what you do. And I think that's really important thing, just to, in terms of from a patient's perspective, it doesn't feel like it's a major thing. It's not a major different thing, but yeah, that incorporating that just activity into the daily activity. I think some interest in the Johns Hopkins work in particular. I think I picked up there from some of the comments in the chat as well. So what I'm sort of, I've got Kirsty, hand. Anybody else wants to ask a question, put your hand up or pop it in the chat, but I'll come to Kirsty now.
Thanks, Nick. Not so much a question, but thanks for the inspiration idea of the activity, or the trolley with the activities. We're just actually changing over some of our medical trolleys, and somebody's gone to go and find a load of them today, because we want to populate them with activities and then be able to move them around the wards, decorate them and make them look different. But I did see that picture on the WhatsApp group, and yeah, dived in, found a trolley, and we're sort of actioning that. And just another thing, I know probably Juliet's thinking this as well. We had one of our consultants present yesterday, and research that was done, I think, in Australia, that said that the biggest intervention that could make a difference with falls was actually promoting mobility, which I'm sure we all know. But 25 minutes of of walking a day had an impact and made a difference. So it's really interesting. I could see Juliet wrote making notes, the fact that you've actually got some way, because we said, well, how can we record this? How can we get staff to acknowledge and record that each time a patient went to the toilet, each time they walked or wherever they went, you know, how can we record it? And then it was like, you've just come up and showed us that's how to do it. So yeah, I'm sure we'll be talking about that. Thank you. Thanks. Great.
Thanks, Chris. I think Fiona put something in the chat before. I think we can underestimate the level of awareness isn't as ubiquitous as we possibly think it is. You know, we in this space, this is our thing. You know, we're passionate about this, and we understand this. So the point that you made there, Kirsty, about, you know, we know people know that movement improves or reduces the risk of falls, right? But we know that, and I think that, we shouldn't underestimate the level of awareness raising that we still have to do in terms of some of the basic stuff from our perspective. But it won't be basic to other people. It'll be new information to them. So don't forget to keep on repeating the simple stuff as well. The comment from Fiona was about a frailty SHO who hadn't come across the term deconditioning, and you'd think that was kind of, where is that? But you just have to accept that's the reality of the world. You know, that what we know is that we have a passion for this, and we understand more. So don't forget to repeat the simple stuff. So before I hand over to Kate, Amit.
Yes, absolutely. I think that, as I said earlier, I mean, it's only about, in practice, we've been using this term only for the last 7 or 8 years, although the term is not new, but the understanding is rather new. And in the context of deconditioning as a syndrome is very, very new. So I'm not surprised that the frailty SHOs, many of them wouldn't know. And if the frailty SHOs don't know, then the others also have a less chance. But speaking with Bruce Keogh, the previous medical director of the NHS England, he said, well, he wasn't aware of the term deconditioning, but he was aware of the fact that if they put somebody on for a bypass surgery for the heart, and he was a cardiac surgeon, he knows that when the patient goes on the operating table, he is 70. When they come out, they will be 80 years old. So, and he said, well, now I understand what they went through, and that was deconditioning. So, you know, it's hearing from the National Medical Director, or well, previous National Medical Director for the NHS, that's something really interesting. But on the other hand, I can promise you, I did not do this, but I saw some of the undergraduate medical students' examination questions, and there was a question on deconditioning. So it's percolating, and part of this is because we made a deliberate attempt to inform the schools of medicine, nursing, pharmacy, and therapy, the Council of Deans, to include deconditioning as part of their curriculum for all these 4 domains in medicine, nursing, pharmacy, and therapy. So I think somewhere people are listening.
Yeah, I think it is,
which is a success.
Chipping away. You know, this is not going to be an overnight change.
No.
You know, this is about continuing having a conversation. I know friend and colleague Ian Sturgis, geriatrician, who come up with the term hospital-acquired functional decline. So we know the shift in practice when hospital-acquired infection became a thing, and it was used in that way. You know, we talked about hospital-acquired infection. I know we're talking about hospitals here, but this, giving it, like Amit says there, about a condition, a syndrome, a thing that we can attach it to, almost like a medical condition. I think we'll, you know, as practitioners, as therapists, as nursing, it's less about the medical model. But when it becomes a medical thing or a thing that we can attach it to, it gives it a level of importance, I guess, which can then be taught in schools and college and universities, to say this is actually a thing that we understand more about now. and we've got the evidence start to back that up. And all the work that you're doing adds to that. And as we saw from Becky there and from Kirsty, we started to collect data. Now we started to show the impact of this, whereas before it was probably anecdotal, that we couldn't really add that level of detail to, and that's just only going to improve over the years. So yeah, really important point. So without any further ado, Kate's hung on, listening to us deliberate over where we're at the moment. But I'm going to just throw over to Kate. Update from you. Let's hear what you're up to then.
I'm hoping everyone can see my screen.
Yep.
Perfect. Okay. So hello, everyone. My name's Kate Tantam. I'm a specialist sister in intensive care rehabilitation down in the southwest in Plymouth. And I started the Rehab Legend campaign. And I'm here to talk to you about the latest stuff that we're doing with Rehab Legend and how I actually need your help and how I want to share all the amazing work that you're doing too. I've got a tickly cough now. So it's all about the patient stories. And I'm going to tell you about the patient story that started Rehab Legend. So Rehab Legend started, and my journey into rehabilitation started from a patient questionnaire I read back in 2016 of a young 35-year-old who left intensive care and was left with a profound sense of loss, a cognitive impairment after being in intensive care, the incapacity to be able to care for her husband and her children and even her dog, and a significant amount of post-traumatic stress related to a delirium experience she had in intensive care. And the questionnaire, the feedback questionnaire moved me so deeply that I was driven into making a rehabilitation service in intensive care, because at that point we just didn't have one. We had surgical physios that came, but we just really didn't understand post-intensive care syndrome and the impact of post-intensive care syndrome in this population. So we know that that manifests, as I said, with her story, mental health, cognitive and physical impairments after intensive care. So I used her story to be able to kind of, as a catalyst for me to be able to build a team. And I'm really proud to say that we've now got a multidisciplinary team of 17 in our department from every discipline. And we are doing all the good stuff, optimizing functional activity, trying to think differently with our goal setting, with our personalized care planning, with our animal assisted therapy, with our modes of ventilation, with everything. And so we wanted to really take forward our rehabilitation ethos in our department. So what we did is we came up with a hashtag, and we came up with a way of making our nurses and staff keen to be part of our rehabilitation campaign. So we came up with Rehab Legend, and that's my kitchen table, and that's a light box I bought from Sainsbury's for £9.90. And we coined the phrase a rehab legend. So anyone who's done anything to enhance, support or promote rehabilitation. And we then started to share our patient stories, and we've been sharing our patient stories since 2018. And you can see some of our stories on X and on rehablegend.com if you're interested. And I know I'm hoping quite a lot of you have heard of us before. So I thought I'd tell you one of the stories that led into the First Steps campaign. So this is a gentleman who was with us back in January 2018. He came in with a really, really, really nasty flu. And as you can see, he's fully ventilated on 100% oxygen. And that night he was fast tracked up to the Brompton to get some ECMO. Here he is in the Brompton having ECMO. So that's extracorporeal membrane oxygenation. So that means his heart and lungs function is being taken over. Here he is filtered in March. So this is, he's now got multiple organ failure. And this is the day that he came back to us in April with his daughter. And when he came back, he was profoundly low. And we had to do a lot of work to help him re-engage into what recovery meant for him and how we had to get him back on his feet and back to the things that he wanted to do. So this gentleman was still at work when he became unwell. And here he is taking his first steps. This is him. Oh, I was hoping the video would play. This is him in our gym, supported, and we videoed these first steps, and we wanted to share them with his family and with the clinical teams that had cared for him, because it took us 6 months to get him to this stage. And this is the day he was discharged from our local neuro rehab centre. And so what we did is we shared his story on X, now was Twitter, now X, and we tried to tag in to quantify all the people who'd cared for him to make sure that everyone realised that rehabilitation and that recovery is a team game. It doesn't matter the colour of your trousers or what you do. It matters that you're in the room helping the patient, and I don't care what you do in any healthcare organisation or care organisation, you are as valuable as anyone else. So everyone played a part in his recovery. So we put his story on X, and we were thrilled to be able to see that some of the medics who'd cared for him up at the Brompton were able to respond, so we could share that feedback back with him. So we're using Rehab Legend stories to motivate, innovate, and challenge what we were doing. And that's where this extra development has come from. So here he is back. This was just literally before COVID all kicked off. And he took off his oxygen because he said he didn't want to look unwell. But I love how his wife is looking at him in this picture. So we took Malcolm's first steps and we've developed it and we've taken it a bit further. So what we've done is I am working with a national team to try and raise awareness. And I'm raising awareness because this is my kind of favourite quote about intensive care, because this is the thing that I think all of us should be doing in every hospital, about optimising patient experience and supporting patients with the level of impact that it is about being in hospital and being just completely overwhelmed by the process. All patients want to get their life back and they feel overwhelmed and they just often need support and know where to start. So what we're trying to do is we're trying to raise awareness about rehabilitation and about sharing rehab stories. So I have been really, really lucky and have managed to get a private PR company to support us with this campaign. And I've been working on this for 18 months now. This was a end of COVID brain wave, because what I wanted to do is I wanted to capture the fact that we know recovery after being in hospital, irrespective of why you've been in hospital, is way, way, way more difficult, I think, than people give it any credit for. And then we actually make it harder by keeping patients in bed, not optimally supporting their nutrition, and not optimally getting them back on their feet and back to their loved ones and back to the people and things that they love doing. So, as I said, COVID was the massive motivator for me. I knew that COVID was a time that was the best and the worst of time. And after COVID, I think my colleagues and I just thought, right, we have to change policy, we have to change public perception, and we have to continue to share the amazing rehab stories that we have, and to encourage everyone to share their stories. So this is where this campaign came from. This is a campaign where we are sharing 8 stories from the Southwest. I tried to get other teams involved from across the UK, but because of the operational pressures in November and December, I wasn't able to get past the first hurdle with lots of communications teams about videoing patients in hospital. So what we did is we videoed patients taking their first steps. And we have 8 patient stories. I've got 2 strokes, a brain tumour, so these are patients from my hospital and my local rehabilitation centres, because they were the ones that I was able to get access to. And so we have got patients to agree to put paint on their feet, paint laced with sand, and we've got them to walk across vinyl, and we've got 11 posters going up across the UK, England, Ireland, Scotland, Wales, with sharing their story. So this is real footprints, real tactile painted footprints on a poster that are going around with this wording, because I think the public perception of rehabilitation is very poor. I don't think people really understand what rehabilitation means and how we can optimize patients' activity in hospital. And we wanted to highlight the fact that rehabilitation services are chronically funded across the UK, and that we're really struggling to be able to recruit and retain our amazing clinicians in the NHS. So we wanted this to be twofold. Firstly, to raise awareness about rehabilitation, but second, to shine a light on the excellence and beauty and wonder that is everyday success in hospitals. And we're going to use these posters across the UK to drive people towards a petition. And the petition is going to be a government-based petition on the gov.uk one, and it's going to be asking for a lead for rehabilitation in every hospital and health board in the UK, and in Scotland we're pushing patients towards the other rehabilitation petition that Scotland are doing. Oh, my slides have just gone excitingly. That means my network's gone. So at the same time, we also videoed the patients taking their stories. And as part of every poster, there is a link to, on the petition for rehab, there's a link to all of the patient stories. So people are able to hear in the patient's own words what's really important to them and their story. And then the second part of the campaign is a first words radio campaign. We wanted to build in lots of different narratives of therapies and rehabilitation, different rehabilitation teams. So we asked a patient if she would be prepared to share her first words. So, and I'll send these slides around so you can hear Claire's first words. So Claire had a spinal cord injury after falling off a horse, a C2 injury, and she was still ventilated. And these were day 3 of her starting to talk. And the words that she uses are "rehabilitation matters, please join our campaign." And we've been very lucky to be able to secure a celebrity to be able to voice the campaign. So it's about raising awareness and pushing people towards action, that rehabilitation matters, and rehabilitation really needs to be embedded in all clinical hospital strategies. So what am I trying to do? What is all of this for? This is about sharing the patient's stories in line with collecting the evidence base, if we talked about the importance of using data, and also linking that to the health economics of why rehabilitation and why deconditioning is such a massive problem, and why we need to, as a team, be coming up with really novel and wonderful ways to get patients back to the things and the people they love. But we need to make sure that we're getting those stories to the decision makers, to the people that are able to make a difference. So as part of this campaign, I'm also doing some work with the House of Lords and the House of Commons and with all party parliamentary groups to be able to get people in the upper court and the lower court aware of what's really important. And part of that is about giving parliamentarians the metrics of success that they need. They need to be engaged in their local hospital trust, because that will be the thing that they get voted in or out on. So we know that this year is an exciting year in politics, and we know that that gives us a unique opportunity. So I want to use that unique opportunity that this year is providing to be able to support patients, support parliamentarians with understanding the importance of what we're trying to do and getting them into hospitals and into rehabilitation spaces to be able to do it. Now, I recognise this is a massively long, terrifying journey, but this is about what we do next as a team, and that everybody, including this gentleman, has a right to rehab. And the thing that is most poignant about him and his first steps and his story and linking it all together is that he didn't get as much rehabilitation as he needed in the community, which is why this campaign is being shared and being supported by the Community Rehabilitation Alliance and the CSP, because what we're really trying to do is we're trying to promote that rehabilitation matters for everyone when you're in hospital, if you need rehabilitation after you leave hospital, but also what are we doing for our patients long term? We need to get them back to the people and the things they love. And it's just about sharing these wonderful stories. So what do I want? There's always going to be a request, isn't there? What I want from you is I want you to share your rehabilitation stories. And when we go live in the 3rd week in February, I would love you to be able to share the campaign and share some of your local stories to promote the wonderful work of you're all doing and the wonderful and the importance of deconditioning and rehabilitation in hospitals. And I want to provide you with some support to be able to welcome your MP into your centre to be able to petition for your local services. Because if we can share your local services, we can give context to your parliamentarians, which gives you and your board extra capacity to be able to petition for extra services and extra finance to be able to support you and your patients and your services. So this is a plea from me to you to work with us and to share the campaign to be able to promote rehabilitation and awareness of rehabilitation in the UK. Thank you very much.
Thank you, Kate. I mean, as inspirational as always. If you probably haven't had a chance to look at the chat, but you'll have a look back at the chat. Lots of messages in there supporting your work, and I'd encourage everybody to respond as much as possible. Kate, if you want to write me just a kind of email which I can forward onto the whole group, because there's a bigger group out there which not always able to join, so I can then forward that on to the 400 and something that we've got, 500 and something we've got on the list. So if you can do that for me, I can share that out. But everybody, if you can, just pick up that mantle. Really, I think patient stories are really important. I think we've just seen that again. Whatever context you find yourselves in, picking up those patient stories. We talk about data a lot. What actually shifts people is the stories. Data links the head, stories link the heart. So and you need a bit of both. But
this year is such a unique year because we know that parliamentarians are going to be wanting to get re-elected. We know that there's going to be hot competition. We know that we have a unique opportunity. So this year, people, is the year to do this. This is why if we can all pull this together, it really feels like we'll have some traction to be able to really, really push. And the overall, so I've got a piece in the House magazine, which is the magazine for the House of Commons and the House of Lords, of a rehabilitation story. We've got pieces hopefully going into the Times. We're trying to go on Woman's Hour. We're trying to get Times Radio. We've got Virgin Radio free for a week. I've got billboards across the UK. The point about this is I need all of you to share, to be part of a tsunami of rehabilitation matters. And this is what rehabilitation looks like, because people don't know. And we need to make sure that rehabilitation is not just seen in this context of drug and alcohol rehabilitation, because it really is. If you ask most of the general public what rehabilitation means, that's where they go. So what we have to do is we have to be sharing mental health stories as well as physical health stories, as well as cognitive. We have to be hearing it from every environment, in every patient group, in every population, because it covers all of them. And we know this is what parliamentarians want, so we have to give it to them, but get the thing out of them that we want too. Which feels like I'm using people, but I'm not. I'm using them to make sure we're getting what we need for our patients. So it's not bad, she says.
I think there is it's not. I don't think it is using people. I think it's finding a way to share the right message. So I think what this is for me, this is a message for the whole group. Change does start with us. It's nobody looking to other people, and you may not think it's possible, but you just give it a go. You never know. Kate, for me, is an example. Having heard Kate's story before, it's just about deciding to do something. And there's lots of people on this call and on the wider network who are just doing stuff because they feel passionate about it, and you never know where that leads to. And I doubt Kate really asked permission much to do the stuff that she's done in the past. So when you ask permission, it probably leads to barriers. So seek forgiveness rather than ask permission. So putting that call out to people, asking your MP to come and see you, all those kind of things. Who knows? You may not get a response, but you never know. And I think in terms of how you connect with other people, how you connect this work, you may feel like you're pushing uphill at times, a lot of the time. And I see comments, about rehab units or rehab beds being closed, and there's difficulties that we find ourselves in, but change does start with us. So you take Kate as an inspiration, just to feel like you can make a difference, and you never know where that leads to. So once again, Kate, thank you for that. I know you often share your slides. I've got the rest of the slides from Bristol and from Becky, so I'll circulate those round as a single pack with the link to the recording if you want to sort of go back and watch any of this again or share with other people.
The only thing I would say is, because this work is embargoed until the 19th of February, so I go live on the 19th of February, so I can't share with you the posters. The posters will change slightly. They're very, very particular on the colours, so I can't share the actual poster and the actual words campaign, because I'm trying to make it a really hard launch in February, because then it means I'll get more media traction. But I just wanted to make sure you as clinicians were aware of what we were doing, and that if you wanted to line your stories up, if you want to line them up for March, April, May, June, and then we can have an event in the House of Lords in early summer, that would be perfect. And I would be looking to share everyone's rehabilitation stories and be able to get as many people as we can to a central event to be able to really promote and push. Brilliant. So that's my only auspices, that please keep it, please don't tell, please don't share the pictures of the posters until the end of February.
Cool. Thank you, Kate. Right, and it's go on, Amit.
No, absolutely. Thank you, Kate, for that amazing inspirational work that you've been doing. And I earlier said Nick was a one-man army, and Kate, you are bigger than an army.
Indeed, absolute force of nature is down on the south coast. Joe, I've got the floor. Joe Macaulay, the floor is yours if you wanted it. You mentioned about you are doing something in April. You wanted to invite people to participate in some work.
Yeah, so it's just a very small ask. We're running a local physical activity champions network, very similar to some of the ideas that other people have spoken about here today. And they would really love to hear what's happening around the country, as well as sharing stories within the trust. So if anybody's got like a small 10-minute presentation, they'd like to come to an NU8 Nottingham University Hospitals meeting, share some of what they're doing. Some of my colleagues would be very grateful, because not everybody can always make this meeting. So yeah, it would be really, people would be really interested if anybody wants to get in touch with me. I'll put my email in the chat, and Kate, I'll definitely be in touch about rehab. Amazing, thank you.
Thanks, Joe. Yeah, pop your email in the chat, and then people can contact you outside the meeting. Brilliant. So lots of information to take on board today. Recognising this has been quite full on. Hopefully, it's been helpful in terms of just sharing. We like to, share as much as we can, but not to overwhelm too much. Hopefully you'll take away being more inspirational. On a very selfish point of view, I'd have this meeting every day if I could, because it's probably the best thing that I do at the moment. Don't tell my colleagues that, Zoe. But it really is one of the most fulfilling and sense of motivation, listening to you guys and you coming together. There was it's just a really positive movement, really, in terms of how we can make a difference in our own area. So keep it going, and let's bring some more people to the group if we can. So thank you for your time again. We're going to wrap things up with 5 minutes to spare, so you can go back and have a little cup of tea or a biscuit or something, or have a breather. Any questions? As usual, you've got the contact details for the people who have spoken today. I will share all the details with you, slides, recordings, whatever. Next meeting we are looking to pencil in, just bear with me, I should have had these details ready, but I'll just check my diary. I think it is the 26th of March. I think I've kind of broadly penciled in at the moment, but I'm pulling together a few bits and pieces. So 26th of March will probably be the next meeting. Kate, last word from you.
It's not a last word. I was going to ask a favour, actually. I was going to ask if anyone would like to be part of a big central piece of work and doing some work with their parliamentarians and some people from the House of Lords. If you are interested in being part of that conversation and being a bit more active in that arena, if you want to drop me an email, that would be perfect, because I would be really happy to bring you in, because I need representation from across the UK. And also I wanted to ask Amit if he wanted to be connected I've got a few contacts for you, Amit, that I need you to share some love with. So I'm going to drop you an email. So while you're on the call, I was like, oh, I'm just going to pin him down now.
Yes, absolutely, Kate, and we would very much welcome any chances to spread the brilliant work that you're doing. So yes, absolutely, we'll be delighted to be part of that. And I've seen the email that you sent in the Community Rehab Alliance, which I am a co-chair of. So we're spreading your work around there. So that's really useful work. And lastly, I think before we finish, for colleagues here, if you have some ideas on what we need to focus on this year, please do share with us, and keep sharing the brilliant stories of the work that you're doing. And if you're doing something, do copy at Recon Games UK, or me or Nick, me at Better Aging and Nick at Wolves Boy, so we can actually put your stuff in both the Recon Games folders and NHS futures pages. So
Thanks,
thank
Amit.
you.
Yeah,
and
good reminder. So we will do a little session in the March meeting just on your thoughts on what we can do this year. We've done the games twice now, the East of England and then the national. So it feels like what's next, and I think we just sort of think about that. So have some thoughts, and we'll bring that back to the next meeting. But thanks a lot for your time, everybody, and we'll see you all in March.
Thank you all.
Thanks. Bye.
Bye.